Okay, welcome back. And again, my apologies. I'm just having some technical issues on my end for some reason. I am opening up my webcam. I had a few requests so that people wanted to see me. So here I am. I'm not actually up at home today broadcasting. I'll probably eliminate my webcam soon, but some people were saying they actually wanted to see me talk for whatever reason. So here I am. So a few things before we get started today. Every webinar is recorded, so in other words, you can watch it again. Usually we have it edited, and then we will send out an email in a few days with a copy of the link so that you guys can watch it again. Today's webinar is on fractures, and we've treated quite a few in our clinic here in Toronto, and I know many of you out there have. In fact, the other day, I got a call from David Barker, an RMT, and he was starting to tell me about an interesting case he had himself. And I said, well, that's great. Why don't you actually present that on the webinar? So we agreed to that. He was very nice to send me all the information. I did some slides. It's all set to go. The problem is I can't seem to get his audio working. So if not, I'll present it on David's behalf. But it is a fascinating case. So I think it just will speak to how well this type of therapy can help with fractures. So if you have any questions along the way, just ask away. Or no, sorry, just type away your question. I'll get to those questions at the very end of the webinar as well. Okay, let's get going here, and I'll figure out David as we go along. I'm just going to minimize me. Okay. Okay, so a big agenda today. We're going to talk about the cellular effects of PBMT. I always mention that just to refresh your memory. Why we might use PBMT for fractures, specifically what's going on in bone repair as a review. Some of you may have concerns about treating adolescents or children over an epiphyseal plate. I'll address that. And then specifically, I'll talk a bit about fractures, some of the research that's out there, how we approach treating fractures, and our special guest, if I can get him on audio. Otherwise, I will present on his behalf. And then at the very end, actually, I have a special offer for you guys listening in today, and of course, Q&A as well. So many of you that who are watching, you're familiar with the cellular effects of PBMT or low-level laser therapy. As a review, we know that you can increase the ATP production essentially by increasing the activity of cytochrome C oxidase in the electron transport chain. This causes a short spike of reactive oxygen species, or ROS. It activates an enzyme called nuclear factor kappa beta. This is a really important enzyme because it actually triggers lots of positive protein synthesis. Also, light's been known to have increased the activity of calcium ion channels. And also one of the side effects of this therapy is an increase in nitric oxide that's released from the binding of cytochrome C oxidase, and this can photodissociate from either hemoglobin, myoglobin, or directly intravascularly to the extravascular tissues and blood and cause vasodilation. So all of this is going to help with cellular tissue and healing. Many of you have seen this diagram before, and this basically is exactly what I've just described here. So I won't spend a lot of time on that. So why PBMT for fractures? Well, there's actually been a huge amount of research in this field, believe it or not, in vitro, in vivo, and clinical trials as well. So it's been established that in vitro can help with proliferation and differentiation and bone formation. It can help with something called the RANK enzyme system, which basically is an offshoot, not an offshoot, but it basically triggers the tumor necrosis factor and helps with metabolism of bone. In vivo, lots of animal studies, they've shown a lot of positive effects on bone, and in humans as well. They've shown that it can help bone regeneration. A lot of dental research has shown this as well, and helping with pain and functional disability. and I'll present some of that research as well too. So in general, bone tissue obviously can heal itself, but unfortunately up to 10% of fractures may result in delayed union or non-union, which is problematic. So we know that laser therapy can increase the synthesis of DNA, RNA, and the cell cycle regulatory proteins, and therefore help promoting cell proliferation. In bone tissue, in vitro and in vivo studies, as I mentioned before, can help upregulate growth factors, protein, genes, all related to bone cell differentiation. And eventually this will lead to stimulation of osteoblast proliferation and activity. So low-level laser therapy, or PBMT, produces an earlier recruitment of inflammatory cells. This is really important because as soon as you have a fracture in a patient, the sooner you apply light therapy, the sooner you'll get this recruitment of inflammatory cells. And this will lead to a higher amounts of granulation tissue, which is deposited at the fracture site and will help the onset of bone formation. It also produces significant increase of genes responsible for stimulating osteoblast proliferation and differentiation. So laser therapy stimulates osteoprogenitor cells, kind of like stem cells, and their differentiation into matrix-producing osteoblasts, and thus increasing the rate of bone formation and bone ingrowth. So essentially, you're going from a stem cell, like a bone stem cell, to an osteoblast, and of course it matures into an osteocyte for repair. So what happens during a fracture? Well, yeah, we've all studied this. You'll have your initial inflammatory site and a hematoma develops. Then you'll start to get internal callus formation with fibrous and tissue cartilage forming, so a fibrocartilaginous callus. You'll start to get a formation of new blood vessels, and slowly spongy bone trabecula start to infiltrate, and eventually this this bony callus will form and heal up the fracture, and you'll get bone remodeling based on mechanical stress, and you've healed your fracture. So some of you, and I do get this question fairly regularly about concerns about treating around a growth plate, because some of you may have heard that maybe it's an issue, maybe you shouldn't be treating around a growth plate, maybe it causes premature maturation of the growth plate. So according to Physiotherapy Canada, the guidelines for laser therapy, they do list treatment over an active epiphysis as a precaution, not a contraindication. Now, precaution just means that you need to gauge how much dosaging you're using to be somewhat careful. You're treating a child or an adolescent, but it's certainly not a contraindication. In fact, we know it's quite safe. There's been a fair amount of research in the field too. This particular paper looked at the effects of red light on the epiphyseal growth plate in rats, and they used different dosages from 4 joules all the way up to 6 joules per centimeter squared. So that's the energy density. And they concluded from this particular research that low-level laser therapy within these parameters caused changes neither to the areas of the epiphyseal cartilage nor in the final length of the limbs. In other words, they use like a double negative there. In other words, it didn't have a negative effect on the epiphyseal cartilage or the growth of the long bones in the rats. So lots of different types of fractures, obviously, from green stick fractures in children to compound, enclosed, displaced, compression, hairline, blah, blah, blah. We know them all. Of course, the ability to treat a fracture is limited with light, only if you can get light to the area of the fracture, right? So some of these you will not be able to treat because they're definitely in a cast or have some kind of permanent or, well, semi-permanent cast or device so that you can't get a device onto the skin. So it is important that if possible, if a person can be splinted as opposed to casted, then you can actually, in fact, treat it with light therapy. And that's what David Barker, and I hope I can get him on live, did for his patient. So in the United States, there's, again, always a stats here in the US, approximately 6 million fractures happen annually. That's a lot, of which, as I mentioned, up to 10% proceed to non-union. So, common fractures like in elderly or the hip fracture or wrist fracture particularly, right? The wrist fracture is an easier one to deal with because it's relatively superficial, and sometimes you can get away with a splint if it's not a displaced fracture. So conservative treatment for closed bone fractures, or CBFs, in the wrist or hand generally involve providing patients, with a cast, a splint, and obviously medication, for pain. But the treatment doesn't actually involve the fracture site, right? They're just basically saying, okay, we'll stabilize it, go home, don't do anything, it will heal 6 to 8 weeks, and you're good to go. And that's basically how, allopathic medicine is going to treat a fracture. However, guess what? There's photobiomodulation, which all of you are quite aware of. This particular paper was a randomized control trial looking at LLLT for closed bone fractures, or CBFs, in the human wrist and hand. They looked at 50 patients with these fractures either in the wrist or the hand, and they received either laser therapy or a placebo. The laser group had 830 nanometers, so near infrared, 60 milliwatt power. Notice the frequency, 10 hertz. Notice the time, 600 seconds, that's 10 minutes, by the way, obviously. So that's a long time. That's because the power output's fairly low, right? And that was equivalent to 9.7 joules per centimeter squared at the fracture site. They treated 5 times a week, so 5 days of the week for 2 weeks. And if you look at the results, so if you look at the far left, you have the visual analog scale. So before the treatment, the laser group was averaging 6 out of 10, as was the placebo group. The DASH index is a index for disability in the hand. The higher the DASH, the more problem. Then they did a hand grip strength in kilograms and finger grip strength. So essentially the placebo and laser before treatment were about the same. Then after treatment, if you're comparing the two to laser and placebo, the pain went down to a 3.8 in the laser and a 5 for the placebo. The DASH was remarkably improved in the laser group to about 20, whereas the placebo group was still relatively high at 34. A hand grip, you can see a good improvement to 4.56, whereas placebo group was still fairly low at 2.48. And finger grip, again, being significantly higher at 2.32 compared to 1.36 for the placebo. And then 2 weeks follow-up, you can see a continuing improvement in the laser group and a slight improvement in the placebo group. So this particular paper, when you look at the results of what they got, they concluded that laser therapy can relieve pain, improve the healing process of closed bone fractures in the human wrist and hand. Another paper I want to mention, it's an animal model paper. Essentially, what they did here was they looked at creating osteotomies equivalent to a fracture in tibias of rabbits, and some of them received laser therapy, some of them received sham or control. They used near-infrared light, 830, fairly high energy density at 40 joules per centimeter squared, and a power density of 200 milliwatts per centimeter squared. The treatment was applied directly to the skin for 50 seconds at 4 points along the tibial fracture and daily for 20 days. Here are the results. If you look, this was 2 weeks post-treatment. You can see the difference between the laser treated and the control treated. Significant, you can see in the laser treated, significant callus formation, whereas the control was still fairly open. 3 weeks out, you can see a continuation of nice bone healing for the laser group and still quite a gap and certainly significantly less of a callus formation. And then 4 weeks out, you can see that the laser group was healing quite nicely, whereas there's still a significant gap. So it wasn't just a fracture; they actually, did an osteotomy. So it was quite a big gap in between the bone. So again, this is a nice visual representation showing how if you look at Mother Nature and you compare that to adding light, how much more effective healing can be if you add light therapy. They did another, this was a micro CT, and they compared on the left was the laser therapy group, and on the right was the was a sham or the control, and you can see a nice callus formation. It's sort of where that white portion is, whereas you can see a gap and significantly less callus formation. So there was more of a non-union happening in the sham treated. So they concluded here that laser therapy may accelerate the process of fracture repair or cause increase in callus volume, especially in the early stages of absorbing the hematoma and bone remodeling. So it's critical that if you're going to treat a fracture, preferably you treat it right away. So laser therapy can improve, as far as how we approach treatment, we know it can improve the repair process. It can also reduce inflammation and pain for your patient. You do have to expose the light directly to the fracture site. So either removable splint or cast. You can't obviously treat it through a barrier like a cast or unmovable splint. As soon as possible, start treatment within 24 hours, 48 hours if possible is really important. We usually advocate treating daily if possible. You know, it's tough sometimes to get these patients in daily. You know, if you're able to treat even more than that, that's even better. And especially for the first couple of weeks during the early formation of the callus, or the fibrocartilaginous model. And then as it's healing nicely, you can go down to 3 times a week for a couple of weeks, and if necessary, a couple times once or twice a week for follow-up. So that's generally speaking how we approach it. Treat the entire fracture site circumferentially. As far as which protocol to use, we tend to use the standardized protocol for the area that you're treating. So if you're treating a wrist or a hand, use the wrist or hand protocol. Or ankle foot, use that particular protocol. But you can customize to even lower frequencies and lower duty cycles, especially to start. So in the infrared, say the dual infrared, you can customize down to a 10 or 20 hertz and a 10 or 30% duty cycle. And you can start to increase that as we go along. Okay, so this is where I'm going to see if I can get David here. So I'm going to introduce David and see while I'm doing that if I can get him on board here. So just give me a second. Okay. Did I tell you how much I hate GoToWebinar, everyone? All right, let me see here if I can get David here. David, if by chance you could talk to me, that would be great. But I don't know if we're able to hook you up today, unfortunately. Yeah. No, it does not look like I can. I don't know why I can't unmute anyone here. It's such a weird thing. I usually have no problems with this, but so David gave me a call a few days ago, and he said, "Hey, you know, you're doing a webinar on fractures, and it just so happens I treated a young man for a wrist fracture, and I want to share that with you." So he went on to tell me about this. Now, David's been using our equipment for I think over 5 years now as a registered massage therapist. He's done extremely well, and it goes to show you that, you know, whether you're an RMT or a naturopath or a chiropractor, you know, the fact that you can use another type of therapy, whereas perhaps your standard therapies may not necessarily be as effective, or you can use it in a synergistic manner. And David is a living example of that by adding low-level laser therapy into his practice as an RMT. So I'm going to do this for David. And again, I apologize, David. I thought this would be seamless, but it just goes to show you that in 2021, nothing is seamless. The patient was a 14-year-old young man named Nate, a competitive hockey player. He fractured in the game a distal radius of his left hand. He started treatment in October 1st, 2020. So essentially, you know, he wasn't able to untie his skates after the incident. The trainers took him out. They got him to David right away. And he assessed them and David decided, well, you better get it out to ER, get an X-ray image. And I do want to mention this, by the way, that wrist fractures sometimes appear as sprains. I always recommend getting a patient imaged because it may not be evident that there's a fracture at all. Myself, I fractured my wrist. I thought it was just a sprain. 2 years went by, and eventually I had to have a bone graft surgery to repair it. So when I was a teenager. So it just goes to show you that, you have to think what the potential diagnoses are and get imaging if necessary. So he went, this is out in Kingston, by the way, went to urgent care out there. They had x-rays, revealed a distal radial fracture very close to the epiphyseal plate. Again, I addressed this earlier. The ER doc suggested, well, cast it up 6 weeks, then physio. So we're looking at, looking at about 2 months plus before maybe you can return to the sport. David had asked if there was any other way that they could deal with this. He didn't actually get into why, but he asked ER doc if perhaps they could do a removable splint. Reluctantly, the doctor said, okay, as long as the patient agreed, and the patient agreed that they would keep it stabilized as best as possible. And this allowed David to immediately start accessing that area to photobiomodulation. Again, starting treatment October 1st, 2020. So this patient was able to come for consistent treatment up to 2 times a day, which is quite amazing, for 10 consecutive days. So total of 20 treatments. At that point, the patient was actually fully recovered. Range of motion was normal. Resisted range of motion tests were pain-free and normal. Power, grip strength was normal. No pain was reported upon palpation or direct compression to the injury site. Now this is after about two weeks, 14, I think, 14 days or 2.5 weeks or so. So week 3, obviously with COVID going on, there's a bit of a lag to get back to the orthopedic surgeon. And guess what? The surgeon was quite surprised. In fact, after he re-examined, there weren't x-rays done again because he passed all the tests. And he wrote a little script. You can see it on the far right here, that he was able to return to regular sporting activities. So this was, I think, after 3 weeks or so, I think David said, directly to start his sport again. So David did want to emphasize that it's obviously important to keep that splint on to stabilize that area in the sling. Obviously, depending on your scenario here, it was a 14-year-old young man. Probably some video games were involved there, but it's pretty tough to always do that. But it's important to always recommend that in lieu of a cast, with a splint, it's critical to keep it stabilized. So as far as protocol goes, this is how David approached it. He has a LDR 100 probe as well. For those of you not familiar with that, it's a high intensity red laser probe. Light's not going to travel deep with this one, but it's really important for pain control. So he introduced that to the area as well. He also treated proximal to the area to enhance vascular lymphatic flow. So he also did that. So obviously his goals initially were to help to reduce inflammation, help decrease in pain. And then he started off initially with lower frequencies. He used the standardized wrist hand protocol. And then it progressed to the stage 2 protocol, so slightly higher with respect to duty cycle. And he started to do some more laser probe work with continuous wave. And a range of motion was improving. Eventually, he went up to stage 3 with much higher frequencies and duty cycles. And modulating, you can see here even the laser diodes as well too. So again, the beauty about our system is that you have the ability to customize and change up things. And it's really Dr. Khan, who's been doing this for 30 years, every patient's unique, and he would try different types of strategies with these patients to see what's working, what's not working. I do encourage everyone to do that with their patients, especially because sometimes the body can accommodate to the treatment as well too. So I think David has a great example here to show that if you're able to do that and change the settings fairly consistently, the actual results are significantly better. So again, I apologize for not linking David in directly. I keep saying how much I hate GoToWebinar, so I will be phasing GoToWebinar out soon. But anyway, that's the webinar for today. I do want to take some questions, but before we do that, I want to mention we have a basic certification training course on Friday, February the 19th and Saturday, March the 20th. If you haven't been certified, I encourage you to sign up. It's only $199 for an 8-hour course live. We're also doing some advanced trainings in a master class. The first advanced training is on lumbosacral conditions. That's on March the 6th. And we have a June 5th masterclass coming up. I'll have the details of that soon. And then in the fall and next winter, we'll be having some other advanced courses as well. I do have a special code for those of you who haven't signed up for the lumbosacral region. It's Web50 up until midnight tonight. You can get $50 off. So basically the early bird special. So $229 instead of $279. So I encourage everyone, if you haven't signed up, to please do so. Our guest speakers, keynote speaker being Dr. Ben Ewan, a longtime BioFlex user out in Halifax. I think he has about 20 or 30 BioFlex systems, a wealth of knowledge. He'll be talking at length about sciatica, all the different causes of radicular pain in the lower back and the legs. Of course, Slava Kim, our clinic director, will be speaking on stenosis. And I think I might join in as well. I'll talk a bit about how you can approach analgesia, pain relief effects versus healing as far as dosaging goes, and a few other interesting topics as well in the lumbosacral region. Should be a good event. It's 4 hours long on March the 6th. So I do encourage everyone to join up. So I will take some questions now, and I'm just going to see and pull them up right now. If you have any questions for David, by the way, I encourage you to type those in as well too. Let's see here. How can I address periodontal bone? So if you're addressing issues in the oral cavity, our equipment's not really designed for that, but you can treat through the buccal, through the cheek, and you can also open the mouth and using a plastic wrap around the laser probe. You can turn it on with the side of your finger, and you can access probably at least half the oral cavity, depending on how big the mouth is, I guess. A question from Mike Sider. Hi, Mike. Do you find the hospital will cooperate with cutting a window in the cast? I don't actually know. I think they would consider that because there's other, I know that usually at hospitals, they're aware that you can also maybe use ultrasound to help with fractures. So I think as long as it maintains stability, I don't think there'd be an issue with opening up a little window in that cast as well too. A question, can it help with osteoporosis? It seems, research-wise in animal models, it seems to help with osteoporosis, but I haven't seen any human trials, so that's experimental and would be challenging because of it's hard to get a lot of light directly into big bones like the hip, for example. Okay. Could you tell us about the research results regarding old versus chronic fractures? There's no research on old versus chronic fractures, unfortunately. As far as chronic fractures go and non-union, the idea there is that your laser therapy might be able to help with, with that non-union, but it's pretty challenging. So, but unfortunately, there is not any research on that. A question from Dr. Chantal Felteau. Thank you very much. Nice hearing from you, Chantal. For a 16-year-old female with Colles fracture, radius and ulna, a Y plate and 8 screws have been placed. We started 2 days ago. When is the recommended time to remove the hardware? That's really more of a call for the surgeon. You can treat over the hardware. That's not an issue. As far as when to remove the hardware, to be honest, I think they usually make sure it's stable before they do that. So if you're adding light therapy, you should be able to remove the hardware sooner than anticipated. So it's important to communicate with the orthopedic surgeon on that one. What can we do in case of an old fracture? I think I mentioned that already. Someone asked about Raynaud's disease. Yeah, it definitely can help Raynaud's. Of course, that's not a bone issue. Confirming no contraindications with titanium plates and screws. That's correct. It's not a contraindication. Wendy Zelmer, can you email me? You have a question there. I don't really understand it. Just email me. I don't mind addressing that. I understand that earlier the better is an ideal world, but what would be the prognosis for 6-month-old injuries? Again, hard to say, right? Because when you're dealing with really chronic fractures that have non-union, you know, sometimes they have to go back and do surgery. There's different things, so I can't really offer a prognosis just given every case is in fact quite different. Just seeing other questions here. I understand. Okay, sorry. Can osteophytes from trauma be treated or dissolved? So light therapy won't dissolve an osteophyte. It can help with inflammation secondary to osteophytes, but the osteophyte formation is due to mechanical stress, right? It can't directly treat an osteophyte, but it can certainly help with the symptoms associated with it. A question from Evelyn. Hi, Evelyn. A colleague in Ottawa advised that a patient with plates after fracture say that they feel heat during treatment, but it was uncomfortable. Yeah, I don't know how to comment to that. I mean, we've treated many people with hardware. You know, the equipment does warm up, you know, just its natural state because of electronics, especially the arrays do feel warm. So that might be the issue. But there's no way that this light from the LEDs or a class 3B laser has enough energy to heat up metal. It's impossible. Is there any benefit to bone healing, exposing adjacent areas if there's a cast in place? I think, yeah, that's a good question. I think there is benefit to even treating above and proximal and distal to the cast. It's just that you can't get light directly to the bone fracture site, so it won't be nearly as effective. A question from Steve, how frequently can you treat a non-union fracture? Again, a non-union fracture, I mean, usually, you know, if you're treating in a clinical setting, you're treating at least 3-4 times a week. That would be, but if you can treat more, that would be even better as well. So, all right, well, thanks again, everyone. I appreciate it, and my apologies. I was really hoping to get David on live. I was quite excited to do that, and quite disappointed with the GoToWebinar. Sucks. But anyway, again, Zoom soon. Webinars next week, next month will be posted soon. And I appreciate everyone for joining in today. And we'll see you next time. Take care.